Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing pain management. Given the wide variety of conditions that can cause pain, I think this is a topic that sadly will be relevant to many of our listeners. Through conversation with a medical expert in pain management, we'll touch on the different options available to patients suffering from pain. My guest is my colleague, Dr. Yili Huang. Dr. Huang is the director of the Pain Management Center at Phelps Hospital and is an assistant professor of anesthesiology at the Zucker School of Medicine. Yili, welcome to Well Said.
Thank you, Ira. I'm excited to be here today.
So let me first ask you how you've been holding up, given the extraordinary circumstances we've all been living with for the last year and a half.
Thank you for asking. We are doing well. The pandemic has really been a challenge for everyone. For our patients who are struggling with pain, that's no exception. Our patients experience some disruption in care from the pandemic, as you can imagine. I'm glad we're able to be agile and continue to care for them throughout these challenging times. I'm really incredibly proud of our team members who work so hard to create a safe environment so that we can continue to treat our patients.
Yeah, that's great. So to start our conversation off, I'd like to actually get you to define what pain is and maybe what causes pain.
That's a great question because it is so foundational to understanding pain and how we treat it today. The most accepted definition comes from the International Association for the Study of Pain, or IASP. They define pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The way I would think about it is that pain is essentially your body's way of telling you that something may be wrong in your body or something may be wrong with how your body and mind are sending these signals.
So that's interesting because it gets to what was going to be my next question, which is obviously we've all experienced something physically painful, whether it's a headache, a stubbed toe, a toothache, an accident, whatever it is. It seems like pain is just part of the human condition. And so my question was going to be, is there something good about pain? Like why does pain even exist?
I love that question because just by that statement, it normalizes pain as a part of the human condition, right? We often equate pain to suffering, but it's not that clear-cut. A good way of thinking about most pain is that it is your body's natural warning sign. So to your point, there definitely can be something good about pain. The sensation of pain is evolutionary. It tells us to pull our hand away from that boiling tea kettle so that we don't hurt ourselves even more. But unfortunately, not all conditions that cause pain are avoidable. Things like constant wear and tear of the joints caused by osteoarthritis or certain other different diseases can lead to chronic pain. When this pain affects our daily function and our ability to enjoy our lives and lead to suffering, that's when we need to treat it.
Okay, so it's not necessarily the experience of the sensation itself, it's kind of the secondary effect of that sensation interrupting your ability to function in a normal capacity. Is that fair to say?
Yeah, it's more about the whole patient, the whole feeling, right? So pain itself is not really representative of what our patients are going through. Really, function and quality of life is key here.
So a lot of people, I guess almost everybody who experiences pain would first attempt to treat it themselves with, I don't know, a home remedy or some over-the-counter pain medication like Tylenol or Motrin or aspirin or something like that, when should somebody seek clinical advice for managing pain?
To your point, pain is so common, and pain treatments are so ubiquitous. And a lot of times it does not require a clinician. It's really a double-edged sword because having these options to help treat pain and even and these medications are great because it's readily available and it helps us treat our pain and decrease the suffering. But even over-the-counters can have adverse effects and interactions with other medications. The way I think about it and what I recommend for our patients is to seek clinical advice under 3 conditions. The first condition is if pain breaks through despite taking common over-the-counter medications. The second condition is if pain continues while using the over-the-counter pain medications for greater than 2 weeks. Like if the patient has to continue using those medications to treat the pain for greater than 2 weeks. And the third condition is really if the patient has any doubts at all about the current treatment. It's important to recall that foundational definition of pain. And remember that pain is the body's natural warning sign. And something may be awry and may need to be evaluated. So pain that is severe or lasting for a long period of time, that can be pathologic and should be evaluated.
So it's not just that the patient hasn't achieved relief in that period of time, but it's that it may be that there's something seriously wrong that the patient is not treating with just over-the-counter kinds of things.
Yeah, and Ira, that and also there may be something more effective to treat the pain besides the over-counters. And also over-counters, like we mentioned, may have other adverse effects. So we have to be conscious of that as well.
One of the things that I think those of us who are not pain management specialists might struggle with is that pain, like all symptoms, is fundamentally subjective. By which I mean it's experienced only by the patient, and it's not something that we can objectively measure. So I'm a cardiologist. I measure people's blood pressure. I measure how fast their heart is going. I can do an electrocardiogram. I imagine that as a pain management specialist, you're facing a different kind of challenge in assessing somebody's pain level or the consequences of their pain. How do you approach the total subjectivity of this?
That's a real challenge. I often fantasize about how easy it would be if we had a simple objective measurement.
See, it should have been a cardiologist.
Yes, this is a challenge here. Unfortunately, that doesn't exist. The best we have are validated questionnaires and scales that measure pain with a number from 0 to 10, with 10 being the worst imaginable pain. The challenge with that is it predisposes our patients and ourselves to tunnel vision, where we really aim for the lowest possible number to show that our treatment's effective. But pain is complex and it's individualized, right? So a 0 to 10 scale cannot possibly tell the whole story. So, just reiterating what we said before, I think the real challenge today is how do we account for and treat not just pain, but how pain affects function and quality of life.
Yeah, I love that broadening of the perspective. And we'll come back to that a little bit later when we talk about different ways of approaching patients in pain. But I think that's a really good way to frame it. Before we get to treatment, I just want to talk a little bit more about the prevalence of pain in our society, because I've read a number of studies and reports that suggest that chronic pain is becoming more prevalent, and that it's currently already the biggest cause of disability claims and work absences. Do you think that we're in a pain epidemic in the country?
Yeah, thank you for bringing that up. I think just to bring the numbers to light, chronic pain affects more than 100 million Americans. That's more than diabetes, heart disease, and cancers combined.
Oh my God.
Economically, yeah, I mean, it's a staggering number, right? And economically, if you look at the dollars behind it, the Institute of Medicine estimates an annual cost of $635 billion spent on treatment and lost productivity that's attributed to chronic pain. So to your point, chronic pain is a real problem. I think part of that is a lot of our chronic diseases, whether it is just degenerative disease, meaning wear and tear issues that we have with age and just a function of having gravity act on our bodies our whole lives, right? So a lot of these diseases could be osteoarthritic or things like degenerative spine disease, affects us all. And other chronic issues that we mentioned, diabetes, for example, can lead to chronic pain as well. So to your point, I think, we're in the midst of this opiate epidemic, but at its core, it's really a crisis in pain management.
So let's get into pain management. And I guess if we take it from the perspective of somebody caring for patients with pain, before we get to treatments, there must be some evaluation of the circumstances that the patient is in. So what's your general approach to the evaluation of a patient who comes to you with some chronic or persistent pain?
Yeah, the first step is to ensure that we rule out any emergent causes of pain. As you know, as a cardiologist, chest pain can be really a dangerous sign of something going awry in the cardiovascular system. Similarly, lower back pain can also be a sign of something that is potentially dangerous going on in the cardiovascular system. So once we establish that the pain is not emergent, we can have a conversation about where the pain is, what makes it better or worse, and when it occurs. The key, again, is to not just judge the pain in an isolated instance, but to see, hey, at what point does it affect the patient's function, whether it's movement, whether it's the pain occurs at nighttime, and then that can help us pinpoint how to better target it and treat it, and what medications and other treatments to use. We have to have a conversation about pain so that the patient understands that the pain is normal. So starting that conversation is key. And then we set expectations for what level of pain may be tolerable or acceptable so that we can balance compassionate pain treatment with safety, so we don't really do anything that may harm the patient.
Yeah, well, I guess that gets back to what you were saying before. If we imagine this pain scale where 1 is barely noticeable, 10 is excruciating, I guess creating that expectation that you're not going to necessarily take everybody down to a pain level of 0 or 1, but if they're at an 8 and they get to a 4, that would be substantial improvement.
Yeah, and an 8 and a 4 is subjective, meaning that it could be different for different patients. But the key here is that what level would you, as the patient, be comfortable performing things that you need to do? And that's our goal, to get you to that comfort level.
So it's really a kind of functional assessment of more than just focusing on the pain itself.
Yes. Broadening the scope, that's the key to successful pain treatment today.
Yeah, so let's talk about some of the, you mentioned pain medications a couple of times. So what are some of the major drugs or medications that you have available to help patients who are in chronic pain?
Yeah, so when it comes to medications, pain is a complex interplay of injury, of nerves, of the brain. So, it goes from the periphery, so further away from, the central nervous components, to our central nervous system, which includes the spinal cord and the brain. And there's many, many different areas where these painful signals are influenced at many, many, many different receptors. So this is really important to remember about pain, because when it comes to medications, there are many different receptors and many areas that we can target. The concept of targeting different receptors for pain is called multimodal analgesia, so multiple ways of decreasing pain. Many painful conditions are associated with inflammation, for example. So we can use medications that block inflammation to treat pain. These medications may include things like Tylenol or non-steroidal anti-inflammatories such as ibuprofen or naproxen, and even stronger steroids can be used as an anti-inflammatory. Similarly, because most pain signals are transmitted by nerves, nerve pain medications can be useful. Those medications may include gabapentin or pregabalin, and even some antidepressants can be helpful when it comes to treating pain and nerves, such as medications like duloxetine. Sometimes pain is gripping and it feels like spasms, so antispasmodic medications such as cyclobenzaprine or tizanidine may also be helpful. Lastly, for specific situations when none of these other treatments are effective, we may resort to very, very strong painkillers called opiate pain medications.
Yeah, it's interesting that you came to that last in a very long list of other options. And I suspect that that's, at least in part, a reaction to the fact that we have an opioid addiction crisis or an opioid misuse crisis in the United States.
Yeah, it's a real dilemma in pain medicine. We had mentioned previously that there's over 100 million Americans who deal with chronic pain. And one of the most effective pain medications, opiates, are used to treat chronic pain a lot of times. And, the other issue here is that drug overdoses have killed more than 90,000 Americans this year. And 69,000 of those drug overdoses involved opiate pain medications. Wow. It is by far the leading cause of preventable deaths among Americans, more so than falls, guns, or traffic accidents. So, unfortunately, dating back to the late 1990s, there's a direct correlation between opiate prescriptions and opiate-related deaths. So, to your point, there's a real dilemma because, we are dealing with patients who have pain, and one of our most effective treatments for pain is causing a lot of damage and deaths in our societies. So there's a real crisis here.
So let's talk about that a little bit more, because I imagine many of our listeners may have had a significant injury or a surgical procedure or wisdom teeth removed or something like that, where for many years the routine practice was to give people an opioid drug, codeine, Percocet, lots of drugs, names may be familiar to people, that are in this class of drugs. Is that a practice that just shouldn't be undertaken anymore?
Not necessarily. There is a role for opiate pain medications. The role for opiate pain medications is that it is very effective in the immediate post-injury period. So to your point, post-surgically, but not for a very long time. So, and the other role is when it comes to pain associated with ongoing cancer or palliative care. So there is still a role for opiate pain medications. We just have to be judicious with it. Ira, I want to be clear that clinicians are following science and published data. We are all trying our best to balance compassion and safety as we adapt to what we know now about pain treatment and opiate medications.
Yeah, but it does sound like, if I'm sort of listening carefully to what you're saying, that best medical practice has evolved in this way, right? That we're not using these drugs or shouldn't be using these drugs as freely or extensively as we were before. And I guess what you're saying is, yes, but we still have to be careful that we're adequately meeting the needs of patients who have painful circumstances.
Yeah, I'm excited and hopeful about how far we've grown in treating pain in just the last few years, right? It starts with us having this discussion, our patients having this discussion that normalizes pain and setting the right expectations for our patients. Then what we've really done is shifted our focus to beyond just treating pain, right? And focusing on what is important: function, quality of life, and how pain affects that. When it comes to treating, what we like to do is set a stepwise approach to treat pain first with non-drug treatments, things like ice, heat. Throughout the whole process, it's very important to continue evaluating risks and benefits of treating and establishing what the goals for treating the pain are. And to what you just said, most of the time, we never have to use opiates to adequately treat pain.
Yeah.
In some instances, when we do, it's important for the patient, the clinician, and everybody that's involved to understand the risks, benefits, and the goals.
Yeah, I'm really glad that you keep bringing us back to that sort of more holistic view of not just focusing on the pain, but focusing on the patient with the pain and what we can do to make people feel better and get back to a more normal kind of life. Before we get to some of the non-drug approaches that I do want to give you a chance to talk about, I want to talk about medications of a different sort. We often hear about people getting various injections for pain, especially when we're talking about either arthritic conditions or back pain or neck pain. It seems like it's often recommended that patients get injections for dealing with chronically painful circumstances. What's being injected in those circumstances, and how effective is that approach?
Thank you so much for bringing that up, because injections and other pain procedures are really a great part of the balanced approach to treating pain. And they're different because they treat pain close to the source of where the pain is. For example, for back and leg pain caused by things like sciatica or lumbar reticulopathy, we can do safe injections close to the nerves that are pinched and are inflamed to decrease the inflammation. And for things like knee pain caused by knee osteoarthritis, we could deposit medications in the area to decrease the inflammation or improve mechanical motion, or even numb, or even use vibration and needles to ablate these nerves. A lot of the times we use strong anti-inflammatories such as steroids. We also may add in numbing medications like lidocaine. And sometimes we can use other safe medications that alter the decrease the pain and decrease the inflammation in the area. Pain procedures are often a very, very safe component of comprehensive pain care and can be very effective.
And I know you can't answer this for every kind of painful condition and every kind of injection, but in general, are you talking about something that can lead to kind of permanent long-term relief, or is this something that becomes like every so often you need another injection kind of thing?
I love this question because my patients ask me about it all the time. And I wish there was a permanence in relief, and I wish there's a permanence in everything that we do. But so much of a function of what pain is, especially when it comes to degenerative pain, is just a function of wear and tear. So this is what I tell my patients. The key is to decrease the pain for whatever period of time that may be helpful for the patient, so that the patient can do other things to strengthen their body, continue doing things that they love to do. The unfortunate fact of the matter is gravity will continue to exert forces on our body a lot of times. And, the things that we do in everyday life is going to cause additional wear and tear. But these procedures and other treatments and medications, it gives us a chance to enjoy life and gives us a good chance to kind of delay that unfortunate, inevitable downward spiral of pain.
Yeah. So let's talk a little bit about non-drug treatments. And I'm thinking of things like acupuncture, chiropractic manipulation, meditation, other kinds of things that don't involve drugs or needles. Well, I guess acupuncture involves needles, but of a different sort. What's your take on the utility of those kinds of approaches?
Yeah, there's definitely a role for non-drug and non-procedural treatments. To your point, acupuncture does involve very, very, very fine needles, but it's interesting. Acupuncture has been demonstrated to release endorphins, the body's natural painkiller. So there's proof that some of these treatments are effective. Things like paced breathing and meditation has been also shown to have a positive effect in treating pain. Remember, pain is a complex interplay of body and mind. So using non-drug treatments can be really effective to treat both the body and the mind. Another interesting treatment option that we're starting to scratch the surface of, and I'm very excited about, is virtual reality. There's several studies demonstrating, yeah, it's great. They demonstrate, and virtual reality has become so accessible to everybody, right? These headsets. Several studies have suggested that virtual reality can be an effective adjunct to treating pain, whether it's chronic or new pain from, let's say, a procedure or a surgery. And to just round it out, I joke to my patients that, especially when it comes to degenerative causes of pain, that all my patients should be doing some type of physical therapy, whether it's home exercises or directed physical therapy, for as long as they can, forever. Because strengthening the musculature, adapting to some of these degenerative changes and learning how to live with it, but also strengthen your body, is really, really how we combat long-term pain.
I'm really fascinated by the virtual reality thing. Is that just a really effective distraction? How does that work?
Yes, to your point, I think the distraction definitely helps. The studies have demonstrated when patients use the headset for a period of time, they are not concerned with the pain. Now, there's other studies that may demonstrate that there could be long-term effects. Again, pain is a very, very complicated thing. So there's a concept of neuromodulation, where if we change the way our nerves fire, whether it's in the brain or in this peripheral nervous system, there may be a way that we can kind of trick the brain into not sensing pain, and that may be, I don't know, we don't know that for sure yet because it's so new, but that may be a way that virtual reality may help with chronic pain.
Well, that's really interesting, and it leads to my next question. You mentioned nerves being kind of a central part of the pathway between whatever is injured and in our brains. What about nerve stimulation devices, things that are actually get implanted in people's bodies, kind of like a pacemaker that can have an effect on these pain pathways?
Yeah, exactly. So to your point, that is what neuromodulation is. So nerve stimulation or neuromodulation is a really amazing treatment. Classically, it is based on something called the gate control theory, where we basically say, hey, let's distract the painful sensation with some other sensation, whether it's vibration or massage sensation. Let's distract it. And if you think about it, at its very root, so you mentioned pacemakers, at its very root, using electric signals to treat pain isn't very much different from medications, the cardiac medications that you may use to treat the heart, because that's really how all these signals in our heart, muscles, or nerves function. So in this case, you're using nerve stimulation is really a natural progression of treatment. So because it changes the electric impulses in these tissues. Neuromodulation often involves a temporary trial where we test drive these devices for patients for a very short period of time, often less than a week. And if it is successful, we may consider implanting it more permanently. The key to success is for the patient to understand that it is not going to be the holy grail and end all pain. It is. This is an additional tool to treat pain, and for the right patient with the right expectations, it can be life-changing.
Yeah, Yili, this has been great. I just want to end our conversation by asking you to share some reliable sources of information that our listeners who may be interested in learning more can seek out.
The best place to start is the International Association for the Study of Pain, or the IASP, the same group that defined what pain is a great place to learn more about pain, and they're on their website. There's actually links to other third-party resources that are specific for the patient.
Well, that sounds great. Look, thank you so much for joining me today.
Wow, this is really fun. Thank you so much for the opportunity.
My guest today has been Dr. Yili Huang. Dr. Huang is the Director of Pain Management at Phelps Hospital and an Assistant Professor of Anesthesiology at the Zucker School of Medicine. For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.